Good morning, everyone. I'm Thomas Johnson, and I'm the Executive Director of the Population Health Alliance. We have another great panel that you're going to listen to today. This panel will be discussing innovative approaches to addressing social determinants of health for Medicare Advantage beneficiaries. Before we get to that panel, we are going to get a presentation first from Dianne Munevar. She's the Senior Director of the NORC at the University of Chicago. Dianne?
Hi, everyone. Thank you, Thomas. Thank you to BMA for inviting us to speak with you today about the ways MA plans are addressing SDoH, or social determinants of health for their members. Over the past 15 minutes, or over the next 15 minutes, I will share an overview of recently published research we completed for BMA. Included in the research are recommendations for CMS and Congress to increase plans' abilities to address SDoH in their communities. Next slide. For those of you who don't know NORC or didn't know that NORC has a healthcare strategy group, let me introduce NORC. And on behalf of our 2,000 employees, NORC at the University of Chicago is an objective, nonpartisan research organization. Of the 2,000 total employees, our healthcare strategy team consists of 17 individuals with a variety of policy, analytics, and management consulting backgrounds. Next slide. Today, I'm going to share with you a snapshot of our recent research for BMA. Some of this research has been published, and some you're getting a sneak peek of. I'm going to show you examples of what some plans and partner organizations are doing as it refers to identifying beneficiaries with SDoH needs. What interventions are available, including how plans and partners are designing new models of care. And lastly, how plans are measuring the impact of these programs and services. Next slide, please. Talk of social determinants of health or human services is omnipresent today. The World Health Organization suggests that SDoH accounts for 30 to 55% of health outcomes, and that's on a good day. Research frequently identified food, housing, transportation, and social isolation as leading social risks, and all health plans and partners interviewed for this report confirmed that they're working to address these issues in their populations. Then we add a pandemic and the resulting economic disruption, and we see an acute exacerbation of social support needs in Medicare. Next slide. Social determinants of health, or SDoH, are conditions in the places where people are born, where they live, where they work, where they learn and they play, where they worship, and where people age. In recent years, MA plans have increasingly turned their attention to addressing their beneficiaries' SDoH, the non-medical factors that influence health outcomes. BMA contracted with NORC to conduct research to assess the current landscape of SDoH services within Medicare Advantage. We highlighted best practices, and we sought to identify policy recommendations to further enable health plans and partners to address beneficiary social needs. Next slide, please. Over the course of a few months earlier this spring, we saw insights and feedback from a variety of stakeholders in this space. You can see the list of organizations we spoke with here on the slide. We also spoke to some policy experts who've been leaders in either making or tracking policy around Medicare and SDoH. I want to thank everyone who agreed to speak with us, and I hope many of you are in the audience today. Next slide. Despite the broad agreement on the importance of SDoH across the industry, several factors conspire to make SDoH difficult for the healthcare system to address. For one, the organizations that typically address social needs like food insecurity, housing, exist outside the traditional healthcare system, which limit the ability of health plans and providers to directly coordinate services. In addition to the inherent complexity of SDoH issues, there are numerous technological and policy barriers preventing health plans and their partners from identifying individual-level social needs. Technology limitations include a lack of timely data and difficulty sharing information between providers and social service organizations. Policy barriers include Medicare program limitations on offering benefits for services that are not primarily health-related. Despite these barriers, health plans remain committed to addressing SDoH, believing wholeheartedly that these interventions can effectively improve health outcomes and control medical costs. Next slide, please. During our research, we developed a framework to categorize existing knowledge gaps, best practices, and policy. We then vetted and refined this framework with our interviewees. The first step is data sources and beneficiary identification. Basically, what data are available to plans and partners to understand their populations at the individual person level. If plans have beneficiary level information about their members' needs, one would assume they could identify which beneficiaries are in need of social support services. In lieu of standard documented social needs, plans have invested heavily in sophisticated programs to collect these data from other sources. Interventions. Assuming the organization has identified bennies with social needs, what happens next? Do plans have the programs or interventions necessary to address those needs? Many do. And then there's evaluation. Just as health plans are figuring out how to contract for services to address SDoH, they are also in the early stages of figuring out how to evaluate new programs and scale across their business lines. Next slide. So let's talk about what data are available to identify people with social risk factors. Next slide. Okay, if you know me, you know at least one thing about me, and it's that I'm a big fan of Medicare claims and encounter data, but it has its limitations, very big limitations, particularly when we want to use it to identify social factors. The truth is, there are diagnosis codes to flag a pretty detailed list of social risk factors like inadequate housing, lack of adequate food or safe drinking water. There are 9 categories of codes. But the harsh truth is that coding is minimal and it's delayed. A recent analysis found that only 1.3% of all Medicare beneficiaries, both fee-for-service and MA, had an SDoH Z code in 2018. A big barrier to addressing social determinants of health is identifying who has unmet social needs. Z codes are just one way to document SDoH needs. However, without financial incentive for those codes, we expect coding to remain very low. Next slide. Okay, so if claims data aren't super useful right now, what data are available? Well, plans have invested heavily in data assets to identify and track SDoH needs of their members. In addition to claims, there's clinical data. That's data that's available in the electronic medical record. These data can be robust, but again, they often lack the non-medical data, and the information isn't necessarily standardized across systems. Next, we have health risk assessments. HRAs are generally conducted during wellness visits, and questions can be customized to include questions about social needs. The challenge here is that these data are not standardized across systems or the industry. Now, there's an emergence of community-level data and national databases that contain SDoH-focused data. Both data are aggregated to a county or zip code level. And while they contain this robust information about social risk factors, it's not individual. Plus, limited resources make collecting these data difficult. So finally, in the past few years, we've seen an emergence of vendors with technology platforms that collect and track individual level SDoH needs. The technology is also designed to track referrals for services as well as capture rates. Next slide. Our research produced case studies of plans collaborating with their partners to address SDoH. One great example is health insurer Humana. Humana created an advanced data ecosystem, pulling in data from the plan, from the community, and directly from consumers. Together, the data was used to develop its own member risk index, representing 5 health-related social needs of focus. Humana found that 56% of its MA members have at least one social need. Next slide. So with new data comes interoperability challenges, and interoperability causes points of friction for users like physicians who are ultimately tasked with documenting data in the EHR. Healthify, a digital health company, scaled a platform for SDoH that identifies social needs, finds local services, and coordinates referrals in a network with community-based organizations. The organizations can then confirm that the service was delivered, alleviating a major pain point for health plans and providers. Monique Bott, CEO and co-founder, stated it so concisely for us. What doesn't get integrated doesn't get used. Next slide, please. What can policymakers do? Well, CMS and Congress have an opportunity to encourage plans, providers, community-based organizations, and tech companies to work together on this one. CMS should consider strengthening guidance and adding standards for collection of SDoH information. States should seek to share eligibility information on beneficiaries across social support programs. CMS should encourage the use of ICD-10 codes, which identify those non-medical factors. And CMS should support health plan and provider efforts to standardize SDoH data elements and data exchange protocols. Next slide. With adequate data, beneficiaries can better be identified for social support services. What initiatives are plans quarterbacking to respond to the needs of their members? Next slide. Having the necessary data to identify social needs is crucial. Health plans need a bench of partners to catch the referral and provide a service. I want to highlight for you 4 examples of how organizations we spoke with are meeting their members' needs. So first, we have Referral and Capture. When we spoke with Catherine Suberlak, VP of Clinical Services at Oak Street Health, Catherine called it out. She said, there's a lot of harm that can be done if we're screening for SDoHs and there's not a systematic response. We spoke with others who expressed the exact same concern. Plans are investing in partners who can ensure that there's a 2-way connection made on the referral. The referral was made and someone was there to receive it and do something about it. Second, supplemental benefits have been pretty revolutionary and it's becoming table stakes. The top benefits in 2021 were meals, food and produce, social needs, pest control, and non-medical transportation. Plans recognize that they need more direct access to their members. So some plans are working with partners who are staffing their care teams with social workers, and other plans are working with partners focused on in-home support. Next slide. Now, I couldn't possibly talk with you today about MA plans addressing SDoH without spending a little time on supplemental benefits. Supplemental benefits are services or items offered by health plans that are not primarily health-related and not part of the traditional fee-for-service Medicare benefit. For a quick primer, in 2018, CMS issued guidance loosening the definition of primarily health-related and relaxed the requirements that supplemental benefits be offered uniformly to all beneficiaries. Subsequently, Congress passed legislation authorizing new, special supplemental benefits for the chronically ill, and Congress expanded VBID nationwide to allow plans to target target benefits to individuals based on health conditions or socioeconomic status. Over the course of 3 years, supplemental benefits have really taken off. Between 2020 and 2021, benefits increased from 245 plans offering to 845 plans offering. And in 2022, 68 plans will offer meals, 39 plans will offer transportation, and 11% will offer in-home services. Next slide. 2 plans we spoke with, SummaCare and Aetna, shared their experience with supplemental benefits. SummaCare, a regional provider-owned health plan in Akron, Ohio, heard from their case managers that beneficiaries were missing doctor's appointments because they lacked transportation. So what did SummaCare do? They responded by offering a new MA supplemental benefit. They worked with one of their longtime valued partners to add door-to-door transportation for patients needing rides to appointment. And in 2020, SummaCare provided 1,429 rides to its members. Aetna, a CVS company, recognized how devastating the pandemic was on older adults. Think about this. Almost a quarter of Americans 65 and older are socially isolated. So Aetna worked with PAPA, an organization that connects health plan members to college students for doctor's appointments, car rides, house tasks, and other help. During the pandemic, Aetna used PAPA Pals to to deliver healthy meals and offered virtual companionship to their members. Next slide, please. As I mentioned, plans are collaborating with providers and community-based organizations to find ways of providing in-home support to older adults, especially those who live alone. We had the pleasure of learning about the Partners in Care Foundation, who's also here today. Partners is a California nonprofit that brings SDoH services directly into individuals' homes. Partners can be the plan's eyes and ears. They can make sure there's food in the fridge and a safe, clean home environment for its members. Addressing those risk factors up front drives proper recovery, restabilization, and effective use of healthcare. Next slide. To keep up all this good work, we recommend that CMS make a few policy adjustments. First, to permanently authorize value-based insurance design authority to promote more innovation in Medicare. Second, CMS should provide greater transparency into supplemental benefits for providers and beneficiaries by listing them in a standardized format on the Medicare Plan Finder. And third, the Centers for Medicare and Medicaid Innovation should continue to develop innovation models that provide MA plans, Medicaid MCOs, providers, and CBOs with additional flexibility. Next slide. So how can we know what's working? What's actually making a difference? Next slide. As health plans figure out how to contract for services to address SDoH, they're also figuring out how to evaluate what they already do. Plans report that the ultimate goal of their SDoH programs are to produce a return on health. At this moment, with limited standardized data across the industry, it's hard to know what's working. With more attention and investment, we can answer questions like, is the intervention making an impact on the quality of care or health outcomes? What's the impact of the intervention on costs of care? Should a plan scale a local or regional program? Next slide, please. In terms of making sense of all the heightened activity around SDoH, plans and their partners need to be able to evaluate effectiveness. At the policy level, CMS should consider ways to encourage the sharing of experiences and effective evidence-based efforts by health plans, providers, and social support services. CMS should work with the healthcare community to identify potential quality measures related to addressing SDoH within MA and the broader Medicare program. CMS should explore adjusting MA payment in annual risk adjustment to include the assessment of social risk factors of plan enrollees. And lastly, CMS should explore modifying MA STAR's quality performance measures to account for social risk factors of plan beneficiaries. Next slide. Thank you all for your time today. I look forward to hearing feedback and insights from my fellow panelists, and I'll now turn it back to Thomas to introduce our wonderful panel. Thank you, everyone.
Dianne, thank you. That was a wonderful presentation, and I think this sets us up for a great discussion. Let me first introduce the panel that we have. We have Cheryl Phillips. She is the president and CEO of the SNP Alliance. As mentioned, we have June Simmons. She is the president and CEO of the Partners in Care Foundation. And we also have Lucy Theilheimer. She's the Chief Strategy and Impact Officer with Meals on Wheels. Welcome, everyone. The first question I want to ask is really a general question to each of the panelists. What do you see as the biggest opportunity for SDoH to make a difference in Medicare? Maybe June, I'll start it off with you.
Well, it's a new day. I think we see tremendous recognition of social determinants, which some of us have been longing for. It has a language, there's a recognition. We need to really build alternative delivery system, and that's been occurring for about a decade. The communities, organizations have been organizing themselves into systems of care that healthcare payers and providers can connect with and partner with, so that there are now networks. As we have networks of physicians, now we have home and community-based services networks that have evolved as regional delivery systems. And so now I think the most important thing is for health plans, health payers, and community-based organizations and government and philanthropy to co-design the new delivery system. It's more of a disruptive change than anticipated. And we see now we have IT solutions that have stepped in place to facilitate the connection of these two rather different worlds, different workforce, different location. This is all work that centers around the home and self-care. So I think co-designing, building out the quality measures, as you said, the identification systems, consistent measures and assessment tools, best practices. There's a whole set of work that now emerging. It's very exciting to really build an aligned social care and healthcare new delivery system and payment system.
Okay, Cheryl, what are your thoughts about that question?
Well, thank you, Thomas. And yeah, so this, just for the audience benefit, the special needs plans are a subset of Medicare Advantage. However, they are very targeted populations. So the eligibility is either you are duly eligible for Medicare and Medicaid, which already implies low income in order to qualify, or you have a serious, potentially life-threatening chronic condition, or you're at an institutional level of care. And I will also say that the majority of individuals, now almost 4 million people who are enrolled in special needs plans, in fact, are duly eligible and thus low income. So we would say we would start with, and it's really where the NORC evaluation and Dianne did so nicely, we would start with how to measure. You got to know who you're talking about. To us, social determinants of health is a little bit like beauty and pornography. Everybody kind of knows what we're talking about, but we have to have very clear, explicit definitions, and definitions that can be translatable, whether it's from a primary care center's electronic medical record, or a care coordinator who is doing a home visit, or a health risk appraisal that an individual is completing. So we need to have standard definitions, and we need to have an intelligible way of measuring. When we have those definitions and we have that measurement, we can then link to individual care plans, which is integral into the special needs plan structure. They are the only type of managed Medicare that requires a model of care that's unique to the special needs plans. It's tied in tightly to getting adequate and important information regarding social determinants. And then lastly, data drives understanding of gaps in communities. So not only do you understand the individual need, but you start to get a picture of the community need and the health plan and their relationship in that community. So I would say our starting point is meaningful data, definitions and data.
Lucy, any thoughts that you have?
Yeah, thanks, Thomas, and thank you for having us here today. So I'm just to clarify, I'm with Meals on Wheels America. So we support the thousands of local Meals on Wheels programs and can help health organizations and health payers access that network of community-based organizations who've been entering the home for decades, right? Those eyes and ears in the home, that's the work they've been doing. So I do think that there's a real opportunity here to create completely new, non-clinical models for how we support individuals in need, the kinds of individuals that Cheryl was talking about. And I do think it takes a shift in mindset. Social determinants or social needs don't go away after 2-week benefit, right? These are things that people live with day in and day out. It's part of their lives. And so I think as we think about how we're going to meet social needs, we need to think about duration. We need to think about different kinds of partnerships. We need to think about prevention versus, solving a crisis. We need to think about not trying to always take a how do we treat the sick model. So I do think there's a huge opportunity here to really reframe how we think about supporting this population, particularly those who are low income and multiple chronic conditions and multiple medications, where their needs are not going to be solved in, overnight or in a short term. And so I think it's a challenge, but it's also a terrific opportunity.
Okay, we've got a question from the chat, and I think if anyone wants to take a stab at this. Are providers reimbursed by Medicare for assessments resulting in a provider logging an ICD-10 Z code?
Providers, meaning the community providers? I think one of the big challenges is the great need for codes, so that there are ways to define exactly what are the right interventions we need to drive this new system of care, and then how can community-based organizations with different kinds of personnel that don't fit all the Medicare regulations be included, because it is an alternative workforce. There are very alternative interventions, and of course, they're not free. They're labor intensive. And they do require an alternate skill set. So building that out, I think, is part of the work that's underway now. People are trying to think through, as Lucy said, the dose, the duration, the frequency, the identification of the critical problem, the appropriate interventions, and how do you create a sustainable community delivery system that has the quality, reliability, and consistency that you need, and is driving other savings that offset that new cost.
Thomas, can I jump? I'm sorry.
If I can jump in, provider
Sure,
may have been specific or thinking of the clinical providers, because the Z code issue is a problem. And I think it gets to kind of the heart. Many physician groups, one, their EHRs don't allow for extra fields. So they're trying to put in the top 3 or 4 diagnoses. There's not even a field space for Z codes. Secondly, the payment system, certainly on fee for service, and many managed care systems don't have any recognition whatsoever for payment for Z codes. So form follows finance. There are some special needs plans who recognize this and are trying to create some incentives for Z code entry, but they're still rather unique and isolated. So I think what the writer of that chat is alluding to is we need to start with incentives even down to the clinical provider side. And I agree, this isn't all about medical care, but that's where we're getting a lot of the data. So we need to start to have a way to make Z codes have a purpose for those that are entering in the information. So sorry for interrupting.
Well stated.
not a problem. Lucy?
Yeah, I'd like to pick up on something Dianne mentioned, which was the addition of SSBCI, right? The supplemental benefits and the opportunity that created. But we also know that no more money came to the plans to be able to offer those benefits, which puts the plans in a very challenging position. Add to that some of the constructs around Medicare Advantage. They have to submit their plans every year, right? They can change their plans every year. Individuals can change where they're enrolled every year. And all of this makes it very challenging to build new kinds of partnerships and relationships across sectors, between plans and community-based organizations, where one year they may be able to do a meal benefit and the next year they decide, well, we're going to do a dental benefit this year. Choices you hope nobody ever has to make, right? Between food or dental care or vision care. But in essence, while it was a huge step forward because of what SSBCI recognized, there's a lot of opportunity, I think, to really build that out and make it more feasible for plans to implement and to make it more accessible for more individuals. Right now, we also have a emergence of a lot of referral networks, lots of referrals going to community-based organizations, not necessarily with the resources to pay for the services that are being referred. So now you've got people who've been referred to services that have waiting lists, right? Because there aren't resources to support them. So I just think there's a lot of opportunity within the clinical construct, but also really looking outside the traditional clinical construct.
It is important to look at the whole, as you note, because now we are developing some methods for identification. They're not consistent, as Cheryl notes. The systems aren't really set up to capture and consistently. We don't have agreement about what the triggers are, which social determinants we want to address. They're not consistent across. But at the same time, we're at this early stage of evolution. We are creating demand. And when you create demand, you really have to build capacity, or you create a kind of a road to nowhere. And so I think that's one of the big risks we're facing right now. Without building out the payment methods, you create backlogs. And as we all know, if you're really in need of these services, it's not really good to refer you into a dead end, because people give up quickly. They already have enough going wrong in their lives. So we need an open door at the other end of the referral, and that means it has to be somehow built into the economic platform of what we're doing together.
And part of that infrastructure on the community-based side, and it's totally understandable, but many of the plans have expressed frustration that they make the referrals, to June's point. There may or may not be capacity, but the plans also don't know who did get served, or who's still hanging out there, or what happened. If it served, did it make a difference? Was there an impact? And so to me, in a true partnership, there is, I know we can simplistically say dialogue, but what we're really looking for is an infrastructure that allows for dialogue between the plans, the person, and the community-based services. So when the plans have mechanisms for identifying whether individual case assessment and health risk appraisal or other methodologies through data capture, and they make referrals, and there's a warm handoff between the individual and the community-based organization, but there's also a mechanism for returning back. Yes, we served that person. Yes, this is what happened. Those are the gaps that we just don't have, and it's not fault finding, because we just don't have the connections yet to make that work.
One add to that, because I think that's such an important point. And I know June talked about networks that are building. We've created a platform and a closed loop to be able to feed back to our healthcare partners. But the interesting thing as well is we set up arrangements with Medicare Advantage plans and other partners, and then the referrals don't come. So, I think it's really important to look at the whole end-to-end process that starts somewhere inside the health organization, and then that closed loop, right? How the referral gets made, how it gets followed up on, how services gets delivered, what we learn about the result and impact of that service, and how we feed that information back in so we can continue to learn and improve as in our whole delivery system. So lots of opportunity there.
But we're redesigning. We're going to have a new system, and it's going to have these various parts playing together. We have lots of things that are owned separately that operate in full integration as care team throughout healthcare and even throughout social services. So I think we realize it's social care and medical care really in a team model with communication structures in place where everyone is sustainable. That's a big change. It's a disruptive change. You're going to make upstream investments. You're going to hope that those will defer or avoid avoidable suffering. You're dealing with modifiable risk factors that you expect to have a result. So it really is part of the care. But that is, as you said, a big mind shift and a big infrastructure shift. But we see some, I know right now I'm part of a group that's working with a number of major national health plans that are seriously at a design table to think through these fundamental issues into new infrastructure, new delivery system design. It's an exciting time.
There is a flurry right now of technology, as one can imagine, because whenever there's a vacuum, then our first answer is often technology, and technology can be phenomenally enabling. But I think both June's example with the partnership and also Lucy with Meals on Wheels, having a disparate third-party app creating a referral for you doesn't always work. And in fact, many of our plans have been frustrated with those kinds of diffuse, untargeted linkages. If you serve a community where there are a lot of Somali immigrants and refugees, having a third-party app that just has a generic meals program doesn't reach them, nor do they trust it, nor do they respond to that connection. And so both Lucy and June, I know, have great examples of how do you partner in the community, whether it's peer community workers, counselors, addressing language needs, addressing health literacy challenges. That's where I think some of these partnerships have the potential to really expand and grow.
We're here to discuss Medicare Advantage. I'm a huge fan of Medicare Advantage, but I think there's a lot to learn from the transformations that are occurring under Medicaid in so many states across America. And they have, through waivers, been a pilot for some of this work for decades. So there is a lot of expertise. There are not the kinds of systems we really need. They aren't scaled. But there's a tremendous amount of experience that I think we can benefit from. We don't have to start from scratch. And some of them are becoming the same plans. Maybe they weren't as cross-payment integrated in the plans in the past, but at least in California right now, everybody's interested in the new Medicaid. And it's a dramatic redesign, but it builds on all that experience. Right. So I think it's a flurry of transformative work where we really want our best people at the table. We want to get it right. We're in an inflection point. Those don't come very often, and if we can make significant, sustainable new models now. Building on that experience, I think it's really important. The pandemic stripped away a veil and demonstrated to us a lot of things that we kind of sort of knew about, but they became so clear that now we really have an opportunity to take them on.
I think that's a great point, June, and I think because of the population that Medicaid has traditionally had to try to figure out how they're going to serve, right, and support. It really gives us an opportunity to think about how do we stratify our model for figuring out who is it that really needs what kind of service, because we shouldn't even try to offer everything to everybody, right? We should be figuring out what is an individual need and target the services appropriately so that we can stretch our resources. And I do think Medicaid has been, it's been forced under Medicaid to really figure out how they're going to stretch those resources to meet the needs of a high need population facing lots of challenges.
And the focus is in the home. So much of medicine is now looking at in the home, technology and just significant shifts in practice are making that possible. So then once you're in the home, you see the social determinants of health. And so then I think it makes it more clear to more people how powerful these are, and they're modifiable risk factors. We just have to make it sustainable. We have to have the right size, right care, right place, right time, right size.
Right. And leverage what exists. I mean, Meals on Wheels programs, not only are they in the home, they're in the home every day, right? They can see what's happening over time, right? They can collect observational and, more quantifiable data and feed that back they can be that extension of the care manager's team and feed that data back to the health plan so that they can try to address needs before it becomes a visit to the emergency room. So I think, leverage what exists, but be willing to understand that what exists is going to take a little bit of, there's going to be a learning curve because it's different than what they're used to. It's different than what they're familiar with, which is great. I mean, and I think this on the other side, community-based organizations need to understand health plans, right? And how they're different and what their needs are, because it's got to be a two-way street.
Let me shift the conversation a little bit. I want to go back to some of the policy recommendations that Dianne mentioned in her presentation. And I think you all know recently there's been a social determinants of health caucus formed within the Congress. Just generally speaking, maybe if each of you can give your thoughts as to the policy suggestions Dianne raised, and or what would you say are the maybe top 2 or 3 policy recommendations that you would make?
I would like to jump in because I think that follows nicely from where June and Lucy were talking. Congress recognized it is fantastic to talk about in-home care. It doesn't work. And so addressing the unhoused and housing insecurity is kind of at the core of so many of the challenges for social determinant issues. I think that Congress has an opportunity, and through this SDoH caucus, to align more closely with HUD and some of the housing solutions. But I'll also offer that some of the plan, a decade ago, even longer, when I was dealing with healthcare systems and pointing out that, we can talk a lot about in-home care, but if they don't have a home, where are we starting from? And the hospital, the healthcare, and the health plan's position was, we're healthcare, we don't deal with housing. That's somebody else's problem. We're now starting to integrate, and I think there are wonderful examples of partnerships where particularly special needs plans are partnering with businesses and entities and counties and cities. I think Massachusetts is a great state model of how you can align the payers and policy and housing providers. There's also special needs plans now that are focusing specifically on serving care to the unhoused. I know that the Commonwealth Care Alliance in Boston, a SCAN health plan, is rolling out a medical group for the unhoused. So to me, one of the starting places is we have to align housing is health. And yes, focusing in-home care is absolutely vital. But if they don't have a home, it's really hard to integrate the care. So addressing, and this is becoming a greater issue for older Americans. Over half of the newly homeless on the streets of LA are over 55 now. So it's not just a young people's issue, as tragic as that is. It's also an older Americans issue.
Jim, any thoughts?
I think NORC did a fantastic job with this report. We haven't really celebrated your the depth and comprehensive view that was pulled in this report. I was very excited to see it, and I think it does look to making changes at the federal level because what CMS does, industry follows. Health plans are not going to get ahead of this very far because they're not going to feel or be safe. So that federal leadership is crucial, and you have captured, I think, some really valuable steps they can take in terms of looking at what is legitimate payment, and then having looked at piloting some of these things. I'm not sure exactly if it's detailed in here, but workforce requirements. We need to not require licensure for SDoH workforce. We may want licensed people overseeing some of it, but it's an alternative workforce, an alternative skill, and an alternative setting with alternative problems. And so I think your report really looks at some of the foundational kinds of changes in looking at how do we code assessment how do we measure quality, what can we pay for, and what are the regulations that accompany that. And that then has a contagious effect of early adoption. So we see these supplemental benefits as a fantastic and threw the door open to this, but just a little bit. Now, basic structural change, I think, is in order. So I commend BMA for engaging you, and you at NORC for doing really a seminal contribution to the field to bring this very full summary. So we'd like to support the whole of it.
Thank you, June. Those are really kind comments. And we really appreciate BMA hiring us to do the work and continuing to work with us over the past few months. I had shared a sneak preview of some case studies. So in the next few weeks, there will be a little bit more out on the subject. So once you see that, let us know. But thank you very much for the kind words.
Lucy, any additional thoughts?
Yeah, I have three things I'd like to throw out there. One is, I think as a nation, we have to make some decisions about how we're going to invest in the capability and capacity building of this human service infrastructure in this country so that it's actually equipped and ready and able to meet the growing demand and need that we're identifying out there. And we don't do that. There's pieces that are there, but then that community, is all about, looking for philanthropic and other kinds of support. They're spending a lot of time looking for resources rather than doing what they should be doing, which is delivering service. So that's one piece is from a policy standpoint, I would love to see more of a national commitment to that. Secondly, I think there's a real opportunity to build on the SSBCI. We introduced it. That could be even more impactful. It could be more expanded, and we need to recognize, and related to that would be my third piece is this whole notion about data. I know that data is gold these days, and the more data, the better. But the reality is there's some things we need to acknowledge about data, and there's some things we could just accept. We know that if people don't have a place to live and don't have food to eat, if we offer that, they are going to be healthier and better off. How much data and research do we need to do to continually reprove that fact? So I think we just need to sort of focus, but also to understand that in the area of social determinants and social needs, there's a disconnect between providing benefits for a limited period of time, 6-8 weeks, and that would be a longer benefit, and expecting real impact on a social need or social determinant. That's going to be very hard to demonstrate meaningful impact when you're trying to solve a root problem, much of which is rooted in poverty, right, and other economic, and social challenges that can't be overcome. We're treating symptoms more than we're treating root causes, right, of what gets people there. And I think somehow we need to get underneath that and try to understand how we're going to solve for the root causes if we want to see change for the long term.
Well, in America, when you compare us to other developed countries, we see a dramatic difference in the ratio of social spending to medical spending. And you see also a difference in outcomes, health outcomes. So I think that is very important. And I think one of the risks we have is some of the technological advances that are occurring that are really important to this are also making a case somehow that the community needs to organize itself. It should not be, we don't ask IT to organize a physician group network. We don't want them to organize a social care network because it is actually an arena of specialty practice, knowledge, and skill. And if we want to really address, as Lucy notes, the safety net that is leading people to fall into the highest cost care with obviously great suffering. If that's avoidable, we can redeploy our dollars. That shouldn't be something where we say we're going to send people out to the community, and we're going to expect the community to find charitable dollars to undergird this safety net. The community has done that for decades. What we see is it's a very uneven, inconsistent, and incomplete response. Again, the pandemic, when we saw all those cars lined up for food, tragic, heartbreaking picture, just illustrated a problem that's often hidden. That veil was stripped, and we see we need to look at the safety net, and we need we have, I think, sufficient money, and there's a lot of dialogue about this in Washington. We hope it goes in a good direction. That will put something in the way of systemic change that's foundational, that can help us to get right care, right place, right time, and a full partnership around the whole person.
June, you brought up Washington, and before I ask this question, I want to remind all of our attendees that you can also ask questions in the chat. We've got about 10 more minutes. So recently, there's been some agreement within Congress of the various committees to include about $153 million in the CDC budget for SDoH related programs. Now, I compare that to studies that I've seen that right now the private sector might be spending as much as $2.5 billion in that space. So just kind of given our discussions, I'm just wondering, what do you think about the seeming agreement, at least, to give CDC $153 million? Is that a start? Is that enough? I'm just wondering what your thoughts are about that.
Well, I don't know that CDC is should be a standalone designer of this system. I think that I'm for CDC. We all need CDC, but I don't know that it's necessarily it can set a vision. But implementing and paying for services, which is what Lucy's referring to, is a whole different matter. And that really takes thinking through if food is medicine and does it prevent, if we get the right food into someone, do we then later prevent in a diabetic an amputation or a series of amputations or blindness or series of other catastrophes that are extremely expensive? And can we find our way to see where are the investments in modifiable risk factors that actually will yield less suffering and less cost, and that we're really reallocating existing dollars? So we see a lot about home community-based services. So I think that's exciting. We're in a discovery phase. And then as Cheryl noted, then there are many enterpriseful people looking at that as an opportunity. So we love enterprise and competition in America, but I'm really eager to have the safety net be solid, sustainable, and systematic. And I was pleased to see a number of national health plans looking at, because even referring and wanting a closed loop, that's demanding work from the community. And if you have multiple IT companies in the same community making referrals, sometimes around the same person, it's creating a whole new level of administrative burden on very limited resourced organizations. We need to make sure this is streamlined, effective, and really thoughtful, or we could do some additional harm to this fragile safety net that we have now that we really need to make robust. We need to build it so it's strong, reliable, and readily available appropriately for the right investments.
Lucy, you have a thought about that? At least I'm going to call it initial investment in the CDC budget.
Well, again, I think we need to look at solutions holistically, and to the extent that CDC and what CDC brings to the table is part of a larger solution. we need to be investing in the whole, and each of the parts will need investment as well, but I don't think it's the only part that will need investment. So that may be echoing some of what June's saying, but I think, we should be looking across HHS, across HUD, across, and all the component parts in each to look at holistic solutions that are going to be challenged because they all have different systems and different funding streams and different ways of working, different priorities. And I think it's just, that's the ultimate challenge, is how do you bring the whole structure together in a new way that looks at solving a problem as opposed to just solving a piece of a problem.
A strategic plan to integrate America's efforts at safety nets.
Just a little thing. Just a little thing.
Yeah, well, it is a disruptive change, but it's an exciting one, because I think we can see now, we can measure so much better. Mm-hmm. So we're able to look at patterns. We're able to gain insight, and with that, then I think we're really in a new position to be able to do these things.
Cheryl, any thoughts you have?
Yes, so anytime a government agency is focusing on SDoH, that is a good thing. It's just not enough of a good thing. So it's wonderful. I think the concern that you've heard somewhat articulated through all three of us is addressing a social determinant for an individual is not a 2-week, here's a meal voucher thing. It's also one of the concerns of the SSBCI, the Special Supplemental Benefits, is this year I may be focused on transportation for the health plan, but next year I'm going to come up with free watches or something. How people are building their lives around solutions needs to be much more longitudinal. And I think the point that NORC brought out in the study also is, if we are going to evaluate the impact of interventions, these are not 6-month or even 1-year interventions. These are much more longitudinal. And so the investment in CDC, it's a small amount, here in the Beltway, we would call that budget dust, but it's good. It's good that there's a focus. But the real challenge is, how do we create longitudinal and sustainable support systems that are partnered with community providers and with health plans and with communities themselves and with states and with the federal government. So I like to see something that looks a little bit longer stream.
Okay, well, we don't seem to have any other questions in the chat. So I think we probably are going to end things here. I again want to thank everyone for participating. Dianne, your report was excellent. I think really kicked off this session very well. I also want to thank June, Lucy, and Cheryl for their thoughts and their participation. I think their comments were very rich, and I think really kind of set the tone for where we're going with regards to social determinants of health. It's becoming a bigger and bigger issue, I think, for a lot of us that deal with the government on a regular basis at the federal level and at the state level. I'm glad there was a caucus created, so maybe that'll bring more attention to the matter moving forward. I want to thank the Better Medicare Alliance for this panel and for allowing me to moderate this great panel. And hope everyone has a great rest of the day. Thank you all.
Thank you all.
Thank you. Thanks for having us.